Morning. Thank you very much for this special invitation to Professor Stefanova and all the organizer. And congratulations for this brilliant program and congress. So I really appreciate to speak about one of my preferred topics on CDH. And so from prenatal diagnosis to follow-up. So we can go on. So you know very well the congenital diaphragmatic hernia is a defect of the diaphragm. So the bowel, the liver, and the stomach going up in the chest. But we know that the main problem is mortality, that is around 30%. And we know that it's more on left side in 80% of these patients. We know that there's a higher rate of associated anomalies, neural tube defects, and cardiac anomaly, midline defects, and also a lot of genetics anomaly. If you have a look to the developmental anomalies of CDH, we are improving our knowledge in the last years, and we know very well there is also a cardiac anomalies, a pulmonary parenchymal defects, so RS in airway branching, and so also a pulmonary vascularity anomalies. So we know very well that this is a pulmonary hypoplasia, a ventricular hypoplasia, and increased pulmonary vascular resistance. So we create a respiratory acidosis, hypoxia, and hypotension, and metabolic acidosis that connect with respiratory cardiac failure and so in mortality. So we try to improve in the last year the overall survival rate that the CDH study group reported around 75 and 95% overall in all the centers that are participating in the CDH study group. So we started from prenatal diagnosis because it's a very long trip in these patients. And so we know from prenatal diagnosis that we started with the use of US. We saw a normal chest with normal lung and cardiac in the midline. And we know very well that in CDH patient there is a shift of mediastinum. We found bowel, stomach, and liver in the chest. But the really important way of the clinicians is to individualize the prognosis. And so we are a lot of predictors of outcome in the last year. We are use the observed expected LHR, the liver position, the stomach position, and we use also MRI for the total fetal lung volume. So very important, like a worse prognosis is the liver position. So we found to check as well as possible the position of the liver using US and also using MRI to understand the percentage of liver in the thorax and correlated with survival rate. In the last year, we are always using observed expected LHR. That this is range from observed fetal lung volume in the CDH patient related to the expected fetal lung volume in the normal fetuses at the same gestational age. And so during time, we divided all these patients in three big categories: the very severe and severe patient, less than 25% of observed expected LHR, the moderate, around 25 and 36%, and the mild one. And also it's very important, the liver position, so we can divide all this population and correlate with survival rate from prenatal diagnosis to the postnatal period. We use also stomach position. We know that stomach could be in the abdominal position or anterior left in grade 2, in grade 3 mid to posterior, and in grade 4 retrocardiac. So all these positions of the stomach, there is also correlation with the postnatal survival. And also we are using MRI in the last year to correlate as better the observed expected LHR and the total fetal lung volume to the outcome, the need of ECMO and survival rate. In the last year, we performed these new prognostic tools we call mediastinal shift angle. It is to quantify the mediastinal shift, proxy of lung hypoplasia, as a predictor of postnatal survivor in fetus with the left CDH. And so we calculate this angle and correlate with the survival. We calculate the best cutoff value of this value in terms also of sensibility and sensibility correlated with the expected LHR. So we move on fetal intervention because we would like to do something for ameliorate the survival of this patient. So fetal surgery is the logical culmination of progress in fetal diagnosis. So the fetus now is a new patient. And so from 1994, we started to speaking about the occlusion of the trachea for ameliorate the lethal pulmonary hypoplasia due to CDH. And they started with an open procedure, of course, with a lot of rate of interruption of pregnancy and also mortality. And so the last year we are moving on to the fetal procedure, more minimally invasive procedure with fetoscopy. And we started to use this procedure in patients with less than 35% of obstetric expected LHR in left side and right side CDH. And in the last year, we are starting with a trial. Now here I would like to present one of our videos on fetoscopy. And we use a maternal anesthesia with local and spinal. We perform also a fetal anesthesia with fentanyl, atropine, and pancuronium. And we use 1.3 millimeter fetoscope. And with a detachable balloon is about 0.6 ml. We normally insert balloon at 26 and 20 weeks of gestation in the severe and also in the moderate patients in the last 2 years. And how we can see in the video, we enter by the mouth and we saw the tongue and we go down to the trachea and we found the right place to put the balloon and starting to insufflation. Normally we remove the balloon at around 34 weeks of gestation. So we wait almost 6 weeks for helping the lung to improving. So in the last year, we participated in the randomized trial for fetal surgery for severe and moderate CDH, and these are the results. Fetal improved survival to discharge in the severe patient, of course with an increased risk of preterm labor correlated with the rupture of membrane, but we didn't find any significant benefit for the fetal in the moderate patient, probably because we performed the procedure later on at 30 and 30 weeks of gestation. So we are changing our mind and we are putting a fetal in patients with the moderate severe earlier at 28 weeks. So what about future perspective? We are studying a new types of balloon, the smart balloon that could be removed by MRI. There is a lot of study on sildenafil and sildenafil plus fetal in prenatal diagnosis, and also the use of amniotic fluid stem cells and the RNA could help this pregnancy avoid breaching the uterus. So there are a lot of future dreaming. And so now we arrive to the postnatal care. We know very well we have to stabilize the patients. We know we have to avoid barotrauma and volutrauma and optimize lung volume. We use gentle ventilation and permissive hypercapnia. Sometimes we use ECMO to stabilize the patient and to perform surgery. We do an early endotracheal intubation and sedation and paralyze. And the ventilation strategy's goal is preductal oxygenation more than 90%, PCO2 less than 65%, and pH 7.2. We use pressure control and high frequency ventilation. And sometimes we use ECMO for the severe patient, but there is a possibility to do something. And it's a heart-lung machine that replaces cardiac and respiratory function. So surgery always after stabilization is not an emergency. And so we go on operative repair. We use laparotomy, laparoscopy, and thoracoscopy. There are big debate about thoracoscopy for the CDH patient. We use this position. We know that in literature there are quite a lot of paper regarding thoracoscopic repair. There's some images with the direct closure of the defect and the using patch. This is our experience the last 8 years. Just we report in the left side patients with 14% of minimally invasive surgery that we are improving in the last year. But we know there is an intraoperative tolerance for thoracoscopic repair, and also sometimes depends on defect size, type C or D. And so there are, in some papers, they report in an exclusion criteria and dynamic instability, laryngoplastia, severe CDH. And there are some potential disadvantages in this thoracoscopic procedure that are reported for a lot of papers, but are very debated in the last year. So no surgical control of malrotation, intraoperative hypercapnia and acidosis, and higher recurrence rate. So one surgery fits all? Probably not. We have to select the patient. Probably there is a chance for severe CDH, and we have to improve abilities and technical skill. And so we move on to the last part of this trip about follow-up. Now this is not the end. It is not even the beginning of the end, but it's perhaps the end of the beginning. So we started with this long trip until adolescence. We know very well the CDH correlates with long-term sequela, auxological, cardiopulmonary, gastrointestinal, neurodevelopmental, orthopedic, and surgical. So during this year, we prepared a lot of paper regarding follow-up, and we know the large volume center had responded to the complex nature of this morbidity with the formation of multidisciplinary equipe to work on systematic follow-up. And also from 2004, we had our own long-term follow-up multidisciplinary clinic. We work together with pediatrician, obstetrician, nurse, psychologist, and also genetics and radiologists. And we perform a specific follow-up clinic timing at 6, 12, 18, 24 months, 3, 5, and 10 years of age until adulthood. We're speaking about the transitional care. We know there are a lot of gastrointestinal morbidity, a lot of gastrointestinal reflux, about 86% during the first year of age, and also a lot of failure to thrive, oral aversion, need for gastroesophageal tube. So this patient need to be followed up and to take care for this improvement, also for the auxological problem. We know that there is a lot of recurrent respiratory tract infection. We're reporting a percentage about 10 and 50% in the first year of age, and also a percentage of pneumonia that conduct to new readmission in the hospital. And also a lot of obstructive symptoms, like they seem like an asthmatic patients, and so recurrent cause, and also progression of obstructive disorder with aging. So we have to take care for the long-term follow-up. We published this paper regarding the unsolved problem in CDH follow-up. And we know that pulmonary hypertension, late pulmonary hypertension, is one of that. We know that there is no prospective multicenter study. We don't know very well the risk factor, but we know that there is a role of ventricular function, MRI, and some plasma biomarkers that can correlate for late pulmonary hypertension. We know that there is a rest under the ashes for a long time and recur later with the deterioration during time's effect. And so we explore our experience about 472 patients, 250 in follow-up, and we have 4 patients with late pulmonary hypertension with late death, and 2 of that went to transplantation. So it's a very big problem that we have to take care. And also we check in literature, and we found 7 other cases that arrived to transplantation during this year. We know also that there are a lot of surgical complications. Intestinal malrotation correlates with higher rate of intestinal volvulus and other obstruction and long-term follow-up. The presence of hernial sac decreases the risk of surgical complication at long-term follow-up. We have 30 small bowel obstruction and 3% of area recurrence in our experience. We know also that there are musculoskeletal outcome, chest asymmetry, pectus excavatum, and scoliosis that is worsening during time. Also, neurodevelopmental outcomes. We have 44% of infants with mild and 13 with severe delay. And also we try to correlate with the risk factor. We know that there are regular educational programs and special educational needs for these patients. And also another big problem, the sensorineural hearing loss, 10 to 50%. We know that it's more frequent in patients after ECMO and with the longer mechanical ventilation. We try also to correlate prenatal diagnosis to follow-up. So what about observed, expected, and follow-up? What happened later on? And we correlate with midterm respiratory auxological morbidity. So prenatal parenteral counseling should improve accordingly. And in the last year, we correlate also mediastinal shift to follow-up. And we take care to the brain, so the MRI in prenatal diagnosis. These findings suggest that the left side may have an impact on fetal brain development with an overall reduction on brain volume. So what about long-term neurodevelopmental outcome in this patient? And so we check also for the fetal, because now we're using a fetal. What will happen in the future in the follow-up? We have a small data. We don't have a big data from a multidisciplinary and multi-group. And so we found that fetal had a significant impact on tracheal size in CDH patients, but the degree of tracheomegaly does not appear to impact on survival or need to respiratory support in this infant. This is very important because we do something, but we know the consequence. And the last paper where we presented at CAPS meeting is regarding fetal and follow-up. So we check what is happening in this patient at 2 and 5 years of age. And we found a correlation with the late pulmonary hypertension. So fetal may initially improve survival in this patient. Our findings suggest potential long-term complications, including gastroesophageal reflux, pulmonary hypertension, and the need of anti-reflux surgery. So in conclusion, it's a long trip from prenatal diagnosis to follow-up. We cannot work alone. We have to work in a multidisciplinary team because we can realize the best results. And thank you very much for this special invitation.